Welcome back to the last block in behavioral health. In this block, we'll talk about substance use disorders. And this topic actually threads through the entire year. We talk about it in analgesia as well and picking appropriate analgesics. We talk about it in behavioral health where we're concerned about choosing agents that are controlled drugs or scheduled drugs that lend an issue for potential uh, habituation and addiction in throughout practice. Uh, Mental health disorders really go side and side, as we've alluded to, with substance use disorders. Typically, for an individual who has any kind of mental health issue that is not appropriately addressed or treated, will often elect to self-treat with a substance of abuse. And there's also circumstances that occur independent of a mental health issue where someone starts to use a substance that becomes very habitual very quickly for them. This is seen also in cases where opioid analgesia is chosen in a subset of individuals, and cases where folks use other drugs or substances that have a potential for abuse. So we'll talk a bit about what substance abuse looks like particularly in North America, but around the world, and we'll talk about ways to approach it. Here's how we're approaching this block in the therapeutics component, but this will overlap throughout the year in the curriculum for you. We'll talk about the basics of substance abuse just briefly, but in lieu of doing that in these presentations that I'm preparing, the CDC has 4 mini modules that I'm encouraging you to go to, and we have a slide on that in just a minute. And so I encourage you to watch these 4. Each of them, you can do all 4 in less than an hour. We'll talk a bit about opioid use disorder, the nature of the pandemic, recognizing and managing an acute opioid overdose, recognizing and managing opioid withdrawal, and then long-term treatment for an opioid use disorder individual. And then alcohol use disorder will follow the same issue, the nature of the condition briefly, recognizing how to manifest and manage, an acute alcohol overdose, how to recognize and manage alcohol withdrawal, and then long-term sobriety options where there's a pharmacologic component, which is somewhat limited for alcohol, but there are some options that might be of assistance. So in the basics approach of substance use disorder, I'd encourage you to complete this 4-part CDC training. We just loaded them up in online for you, the links for them. And the links look like this. You get on the link and then you just do the first training, which is the treatment of substance use disorder, an overview of addiction medicine, the treatment options for substance abuse disorder, effective communication strategies, and finally, care coordination. Again, it'll give you sort of a background bit. It overlaps what you'll hear throughout the curriculum, but I think it's helpful if you've not done these already to consider doing them again. When we think of intoxication with psychotropic agents, depending on the agent, you may see different things. So this table gives you a picture of what acute intoxication with alcohol, cannabis, opioids, benzodiazepines, and stimulants each look like, and then how the behaviors that you might observe correlate with each of those substances. So again, helpful for you to be familiar with this. Clinicians may see this anywhere in practice, but the most common place we see it likely is in an emergency room. So a patient has come in under the influence of one or more of these substances. They're either having an adverse effect because of the substance, or they've been involved in trauma or violent situation or something else that the substance may have been a contributing factor, or they may be a victim of assault. or sexual assault. So all of these are sort of concerns or issues that as clinicians you should be familiar with what the intoxication for each of these look like. Let's spend a little time now talking about opioids, starting with the nature of the opioid use disorder pandemic. The CDC provides up-to-date info. Usually it's a year or two old. But if you go to the CDC website, you'll find whatever the data is currently for opioid deaths and drug deaths from overdoses entirely, of which opioids are a major component. And so you can see the numbers are large, and that almost 300 people die a day on average from a drug overdose. At least that's true for 2021. Also, they are pretty clear that a lot of patients who are receiving prescription opioids struggle with addiction. So you'll see this very commonly in practice, particularly patients who have long-term opioid use. We are quite hesitant to do that outside of hospice palliative care, to do long-term opioids for anybody, but we occasionally need to do it. What you really do want to recognize, and we'll talk more about this later in the year, is you will inherit a number of patients who are on opioids long-term, for which you might have some management strategies about how to do that. We focus on that particular topic later in the year when we talk about pain management, and there's a program we have you also complete called the Scope of Pain. Scope of Pain is from Boston University. It's a 2-hour training that was funded by Purdue Pharma, who was responsible for the OxyContin problem, and part of their settlement agreement in part was to fund this training for practitioners, in a sense to untrain what we as clinicians heard in the 90s from them. There's also links in the website for drug basic information about opioids, heroin, fentanyl, cocaine, methamphetamine, marijuana, for each of these, and the nature of how they present, what the potential for habituation addiction is with each of these, what the concerns are for acute toxicity and withdrawal, and when people run into trouble with any of these agents, how to manage that. And then there's lots of other links in the CDC I encourage you to sort of look at. They'll give you all kinds of data regarding what the nature of the problem is. The Morbidity and Mortality Weekly Report from the CDC lists, the track record on a week-by-week basis for trending not only in infectious disease and virus vaccine preventable diseases, but also tracks things like safety issues with motor vehicle accidents and gun violence and overdose deaths as well. So lots of public health data available via the CDC. You can get that pretty up to date in the Morbidity and Mortality Weekly Report from the Center for Disease Control that's published pretty close to real time. So let's now talk about opioid use disorders, particularly recognizing and managing an acute opioid overdose, which I think you have some appreciation for already. And most of the slides I'm going to pull from come right from the SAMHSA document, which is part of, which there's a link to in the CDC. And this document will also look at posting online in a bit, to make sure you have access to this entire document. It's a great document. It's a long document, but it offers a lot of useful information, and I've highlighted some key content in this document. Tried to keep it as succinct as possible, and I'll try not to talk over it too much, but there's a lot of useful things here that I think outline things to think about with opioid use disorder. One issue is to be cognizant of what opioid intoxication looks like. Often physical findings and mental status changes, as you see here, but it can be totally unresponsive. The kind of difference that you often but not always see with opioid intoxication is constricted pupils, and with opioid withdrawal, dilated pupils. But that is not universal, and there may be other factors that correlate with pupil size as well. It isn't quite as precise as this. There is a strategy in the document about how to prevent, identify, and respond to individuals with the risk for opioid overdose, how to prevent it, how to identify it, and then the response includes naloxone and both nasal, intravenous, and also important, I think, for you as clinicians to recognize what, if anything, is an issue that might be true in your individual community. So is there a pattern or trend for more fentanyl-laced heroin or carfentanil-laced heroin in your community setting? Typically, folks who work on ambulance services and the police department are well aware of, or are the first sort of have the first awareness of when there's a particular problem. If someone has fentanyl-laced heroin or carfentanil-laced heroin, which are both very much more potent than heroin, they may require more than the usual doses of naloxone to reverse that. There are guidelines as far as what are urine testing of drugs. So when you do a tox screen for a patient, there'll be what are the substances of abuse that are part of that tox screen in a urine or a blood analysis. What are some of the other things that can trigger a positive test? And what is the window of time of detection for that? This is very useful to kind of be aware of, particularly if you're working in an emergency room where you're trying to assess what is the ingestion or multiple ingestions that you're trying to manage for this person. There's also a lot of medical problems or issues associated with opioids. You'll get a sense of that as you go through the year, and in your clinical year, you'll see it a lot. The ones I think of most often are infectious disease, cardiovascular endocarditis is a huge complication we see with IV drug abuse and opioid abuse, as well as HIV, but there are other issues as well. They're all kind of listed in this chart. Many of them, plus the respiratory depression associated with the acute problem with opioid ingestion. Here is an algorithm provided by a different set of guidelines for a considered management strategy in the OR for acute opioid overdose, where you're maintaining an airway, breathing, and circulation, you're oxygenating the patient, you're giving IV naloxone with increasing doses depending on how they respond, and you're continuing, if that doesn't work, to use a Narcan infusion or naloxone infusion, which sometimes we need to use a lot of it if it's a carfentanil or fentanyl exposed patient. But you want to be careful not to overshoot that, and you want to continue the therapy with the opioid antagonist naloxone long enough so that keep in mind that the naloxone duration of action may be shorter than the underlying opioid they received. And so while they look great in your presence, 2 or 3 hours later, their Narcan may have worn off, while the opioid, particularly if it involved methadone, long-acting products or long-acting opioids, that opioid intoxication may continue and they may end up being in danger farther on out. For patients who have opioid withdrawal, it's important they are able to recognize what opioid withdrawal looks like. Signs and symptoms listed here. We're also going to give you a couple other tools to help you with that. One is this chart that lists at what early full withdrawal looks like at different grading in different states. But what most clinicians use is the next few slides. It's called the COWS scale, Clinical Opioid Withdrawal Scale. Here it was published in the New England Journal, but is pretty much the standard tool that clinicians look at. If you want to look at both what opioid withdrawal looks like and how to quantify how severe in withdrawal they are, this is a common scale we'll see used. We look and quantify whether they're sweating, whether they're restless, what their pupil size is. We look at whether they have aches and pains or complain of them, have a runny nose, have GI upset, including diarrhea and vomiting, if they have tremors, if they're yawning, if they have anxiety, irritability, and piloerection. And the severity of the presentation and the quantification of their score helps guide you how severe they are in their opioid withdrawal. which helps guide you on how you are going to manage that opioid withdrawal, where they are in that process if they're going through it, and how to work toward making them as reasonably comfortable as possible, but recognizing they feel miserable, they think they're going to die. They won't die from opioid withdrawal, but they'll certainly feel it. There are medications we use for managing the withdrawal symptoms that are non-opioids. The first group is clonidine. Clonidine helps with the autonomic nervous system signs and symptoms of opioid withdrawal. You could use benzos. A lot of clinicians generally try to avoid a benzo because it's yet another substance of abuse. So we don't usually use that. What is more common, though, is to deal with their GI side effects with diarrhea, to deal with their pain with analgesics like nonsteroidals, to give antiemetics for the nausea vomiting, and then for their anxiety, more commonly than a benzo, we're going to give them probably hydroxyzine or Atarax. So that all of these are sort of options that are going to tamp down some of the symptoms of withdrawal. They're not great. They kind of take the edge off of it a bit, but by no means are patients who are going through opioid withdrawal going to feel great. They are not. The medically supervised use of withdrawal with buprenorphine or methadone is possible, but we don't usually recommend doing this, and nor do the major societies do. What basically can happen is they come in the emergency department, we do we give them a 5 or a 7 day, maybe as part of an admission process, a detox with the goal that after 5 to 7 days, they're not on opioids anymore. The problem with this is that the recidivism rate, the rate of using again after the fact, is just so high. This is kind of referred to as the spin and dry method, for which patients just come back for a repeat performance in another week. It's not really a great long-term answer for the majority of patients. It works with some, but basically, if your goal is to get them off of opioids entirely, then you've got to have a very motivated patient who has the kind of supports to do that, and may be a candidate for one of the other therapies we'll talk about in a bit, with the maintenance of sobriety with patients. Probably an opioid antagonist, IM, might be an option there. But we'll talk about that in a bit. But as you look at managing the withdrawal, you're thinking about what the long-term plan is. Are you trying to get this person into a methadone clinic or a buprenorphine office clinic, or using an opioid antagonist long-term IM? So lots of things sort of looked at with a taper. Buprenorphine or methadone could be used, but they're not really great options. They're associated with a fair amount of failure when after 5 to 7 days you get the person off. Unless you've got great supports, the long-term success there is not particularly high. For patients who have opioid use disorder, they need a long-term plan most of the time. Let's go through some of the options here and how that's approached. So the diagnosis for opioid use disorder is published in lots of places. DSM-5, plus the New England Journal had a nice table almost a decade ago on opioid disorder. So I encourage you to sort of look through this chart of how someone is sort of diagnosed with the condition opioid use disorder. And there's the DSM-5 criteria as well. It mimics what that table was. There are lots of terminology that's used in addiction medicine. Here are some of those terms. I will not go through these right now. I'll let you read through them. You can stop the presentation and read through them if you have any question about them. More terms, and more terms, and more terms. Some of these are repeat terms, and more terms. These are also in the document itself, which we'll post, which you'll find in there. But if you have a question, you can sort of say, oh, I don't know that term. I'm not familiar with that term. What does that mean? The 3 treatments in opioid use disorders that are pretty much the standard of long-term care with opioid sobriety is naltrexone at the bottom, for which a patient is not going to be on a long-term opioid. They're going to receive a long-term administration of naloxone-like drug that's going to blunt the beneficial, the euphoria, the benefit they seem to achieve with giving opioids. So it encourages someone who's pretty highly motivated and does not want to get a continuous opioid to remain higher potential remains sober. The methadone and the buprenorphine each have their own place in practice. Methadone has to be managed by a methadone clinic, and so that means someone lives near a methadone clinic and can go there typically every day, but might be 3 to 4 times a week. The advantage of methadone is that it's usually administered in a pretty structured system, and patients usually get not only just the methadone where they're monitored on a daily or regular basis, but they're also avail themselves of often mandatory behavioral support in that setting as well. Buprenorphine is for a patient who might be a little less motivated, but still motivated, can be done as an office practice, and it is really quite helpful for a majority of patients, particularly who don't live near a methadone clinic. And so buprenorphine has really expanded the options for patients to remain in sobriety. And then again, we refer to naltrexone. Each of these options have sort of different sort of benefits and risks, and the slides in here go through what those differences are. I'll briefly highlight some of them, but will not really do justice to this topic. So comparing agents for opioid use disorder, here's the difference between methadone, naltrexone, and buprenorphine, how they work, what are the sort of implications for adverse effects, are there regulations, how are they administered? And here's from the New England Journal review article, pretty similar. So for full abstinence from opioids in a highly motivated patient, naltrexone might be an option. For many patients, though, it's probably going to be buprenorphine or methadone, depending on their availability to go to a methadone clinic, what the shared decision-making process is regarding which option a patient wants. And then the opioid withdrawal sort of protocols are sort of listed in multiple references as well, but we typically don't look at doing, again, opioid withdrawal with the aim of having them opioid-free unless maybe they're going to be a candidate for naltrexone and they're highly motivated with a lot of initial, at least, behavioral support. There are sort of other benefits with all of these depending on the treatment goals for the patient. There's more comparisons of these choices that are related to what the shared decision-making discussion you're going to have. So what are where are they? How effective are they? How likely is someone going to have to come in the office? Geographically, where are they? Who are the providers who can be involved in that? More sort of issues to think about with shared decision-making on comparing those three agents. And as you look at someone with opioid use disorder, the role of behavioral health therapies, which is really across the board, behavioral support goes absolutely hand in hand with the pharmacotherapy of opioid use disorder management. You will not be successful in many of these circumstances. And you think of lots of situations where behavioral support has to go hand in hand with whatever pharmacologic regimens there are. Whether you're talking about, ideally depression management, depression, anxiety states, whether you're trying to do weight loss for individuals, but particularly in substance or drug use disorders, particularly opioid use disorder, really important to have a behavioral component to that. There are guidelines, again, about what settings can be done, keeping in mind that methadone has to be done at a particular methadone clinic only. There are sort of more overview information about the differences among the agents. Again, more overview information. and the nature of the intrinsic activity of the full agonist methadone, the partial agonist buprenorphine, and the antagonist naltrexone. Here's a table that look at some of the different formulations of products that are available, more detailed than we really want you to focus on here, but there it's available in this larger reference. There's also lots of drug interactions to think about. You should become familiar, particularly with drug interactions with methadone. Methadone prolongs QT and affects drug metabolism. So if you have anybody who is on methadone, you may not be managing their methadone at all, but you have to be thinking, they have proof, methadone itself prolongs QT. If you're going to give them an antibiotic that prolongs QT, and those two antibiotics are, drumroll please, macrolides and fluoroquinolones, okay? You have to think about, do you want to consider a different antibiotic for them, okay? If you're giving them other QT prolonging drugs, you also need to be aware of either monitoring their QT on their EKG or considering something that doesn't prolong QT. There's also key education points for methadone. I won't go through that. It's available there for you to look at, but you need to just see the bigger picture here. There are strategies also about benzo use, and we try not to use benzos, particularly because they already have a major substance abuse issue. You don't want to add a second drug on board to that. So clinicians are really careful about trying to avoid benzos for these folks if they're not already on them. So hence why a lot of clinicians will use, for example, hydroxyzine or Atarax for anxiety and sedation. It's not a great drug. It doesn't do perfect. It doesn't do a superb job, but it does a reasonable enough job without having to add the problems of benzos. When folks are titrated to methadone, and this is usually managed by the methadone clinic, not you, but it's helpful for you to see that, you want to kind of get to the point where they're not using drugs, they're not having withdrawal from opioids, but they're also not over-medicated as well. And so the methadone clinic usually tries to get them in a window that is the lowest effective dose that keeps them in that range. Whenever you make a change, and methadone has a pretty long half-life, so as we'll talk to later in the year, we don't really do methadone for analgesia very often. It's only limited to folks who really know how to use it for pain management because it's got a long half-life. It takes a long time to get to steady state, and you can easily overdose someone on methadone. So methadone is a drug that is not easy to manage, and I recommend that you're only going to basically see patients on methadone or continue their methadone. What will be your responsibility is to make sure, independently check that A, they're on methadone, B, that they're seen at a methadone clinic, C, contact that methadone clinic to independently verify that they're on methadone, what dose they're on, the last time they were seen, and then you pretty much continue that same dose of methadone for their opioid use disorder without increasing or decreasing it. You don't increase it without really at all, you don't. And you don't decrease it unless you have a medical reason that there's a complication they acutely have that is related to their opioid use that you need to come down on it. In other words, the methadone dosing adjustment is always done by the methadone clinic. There's, for patients who require it, there's a naloxone challenge. This might be considered for patients who are either starting buprenorphine or who are patients who are maybe starting naltrexone. And you would start with a pretty low dose to challenge a patient to make sure they're not going to acute withdrawal. There's also protocol recommendations when you're looking at the long-acting naltrexone therapy. So there are some key points to think about as practitioners. Again, I'm not going to focus on that here, but it's available to look at. The buprenorphine transmucosal products that are available, the dosage and the dosage ranges that are used are listed here. The medication for management what's the concerns for methadone or for buprenorphine or maybe even naltrexone for folks who have hepatic or pulmonary impairment. There's a list of drugs that are metabolized by cytochrome P450 enzymes that could be impacted by the drugs we're using. Adjusting buprenorphine dosing, there's some guidelines here on how that's done. Again, you're not going to be dosing buprenorphine unless you're certified as a buprenorphine provider. But as you go through that training as a buprenorphine provider, you'll be trained in this level of detail. Also points for patient education around buprenorphine listed here. And also some guidelines for issues with pregnant women who have opioid use disorder. Finally, let's talk a little about alcohol use disorder. Alcohol use disorders, very commonplace. It contributes to death, usually in different ways than opioids. You don't usually see, or it's not all that common to see, an acute ingestion of alcohol or an alcohol overdose to result in death. It happens, of course it does, but it doesn't happen to the same extent. The deaths associated with alcohol are usually related to shortening lives, but can also be in an acute ingestion related to trauma or some other factor as well. So, motor vehicle accidents, accidents with a motor vehicle, like pacing, being drunk or intoxicated in a roadway and getting hit or hurt. And it's particularly problematic in that alcohol is associated in one way, shape, or form in 1 in 5 deaths for people under the age of 50, adults under the age of 50. It's also very expensive for our healthcare system in economic costs. The health effects of excessive alcohol, the CDC does a nice job with this, reviewing it, is the chronic health effects primarily we think of as cardiovascular, liver, cancer risks. Also, we worry about injury, violence, poisoning, unintended pregnancies, sexual assault, sexually transmitted infections, and poor pregnancy outcomes. Depending on the data you look at, you'll find different sources of data for statistics around alcohol, but they all are pretty alarming, and we often don't think of alcohol in the realm of what that means for public health safety, but it's a huge issue for a lot of patients, both the acute and the long-term consequences of alcohol. One thing you need to recognize, and you'll sort of see in practice, is what acute alcohol ingestion looks like in sort of an overdose. There's a classic correlation of blood level of alcohol with certain symptomatology. I encourage you strongly to make sure that whenever you're questioning any kind of a tox screen or substance screen on someone or anybody with an unusual change in mental status, that you're getting an alcohol level, and if you're getting a tox screen, also get an acetaminophen level. You just want to really kind of know all of the things that are involved in what you're looking at. And so you should have a recognition of acute ingestion of alcohol. You probably want to get a blood alcohol level to help guide your therapy, both for the acute management of the alcohol ingestion, but also to know the likelihood of when and where they are likely to go through alcohol withdrawal. So, as we alluded to earlier, what the intoxication of different psychoactive agents can look like, and there is what alcohol often will present like. Here's an algorithm, a couple algorithms here for managing the acute ingestion of some unknown substance in the emergency department, how to do a history, depending on how they are, what kind of steps might be appropriate. And if it's alcohol management, you're looking at a number of algorithm steps about how to kind of monitor and manage alcohol ingestion in the acute phase while you're planning for alcohol withdrawal management as well. What is listed here and we'll briefly talk about is all patients who have nutritional deficit, and we almost routinely do this with every patient who is on alcohol. They will start on IV thiamine as a first dose, and then IM or oral thiamine, depending on their risk for Wernicke-Korsakoff syndrome. We'll also look at electrolyte imbalances, particularly magnesium, calcium, potassium, phos are the big ones, chloride too. You look at their liver function tests and look at their ammonia level. You do a urine doc screen. We'll also get folic acid supplementation and multivitamin supplementation with them as well. There are approaches to also, when you have a patient who has alcohol intoxication or opioid intoxication, verbal de-escalation techniques that you should be familiar with, respecting the individual, and using terminology that is not going to escalate them. So your approach and how you manage them is directly going to relate to how they're going. There's not logic from your point of view. You're going to be insulted as part of this. They might use language against you. You just have to take this in a very depersonalized way, use these de-escalation techniques and move on, because you're going to do your very best to help them calm down, get the management they need, and not hurt themselves or somebody else or you in the process. There are medications that sometimes, though, need to be used, particularly in an alcohol-intoxicated patient, but this could be true for opioid and withdrawal patients sometimes as well. We sometimes see antipsychotics. I think we allude to that in class discussion. Benzos as well. Benzos, particularly if they're part of your protocol for alcohol withdrawal, and we'll talk about that in just a couple of minutes here. Other drugs sometimes used, or other drug, we'll talk about ketamine later in the year. For recognition management alcohol withdrawal, pretty common to see this and very common in healthcare settings. Particularly, you might not even suspect it, but we deal with this all the time. And particularly we see it in med-surg patients all the time, but the service I think we see it the most on, not surprisingly, is the orthopedic/trauma service. Because people come in with trauma, very often the trauma is correlated with the alcohol ingestion. They come in with acute alcohol ingestion. They probably have had chronic alcohol ingestion. And so on your watch, they don't get to drink in the hospital. They go through alcohol withdrawal on day 2, day 3, day 4 of hospitalization. So you need to be really aware of this. So there are lots of guidelines. Here's a set of guidelines from the American Society of Addiction Medicine. We'll also see what we can do to post these online for you. The neuroscience of alcohol withdrawal, important to kind of recognize this. This is worth spending just a moment to read through it, but it has to do with GABA receptors and the nature of how GABA receptors are affected with long-term alcohol ingestion. And when alcohol is used for an extended period of time, we begin to see some changes in signaling and upregulation, which ultimately leads to this high risk for alcohol withdrawal. And so what we see for using our therapies for alcohol withdrawal syndromes are often GABAergic drugs, drugs that will have an agonist action at GABA receptors. The criteria for alcohol withdrawal listed here, I'm going to leave that for also ClinMed folks, but you can sort of read through that. There's also criteria for what alcohol withdrawal delirium presents like. And like we mentioned, the COW scale for opioids, there are a number of alcohol withdrawal scales as well. The most common is this one called the CIWA scale, the Clinical Institute Withdrawal Assessment of Alcohol scale. The CIWA scale is specific for alcohol withdrawal. And you might see some of the same elements you see with opioid withdrawal, but you see different ones as well. You typically see nausea, tremor, sweating, anxiety, agitation. We see those with opioid withdrawal as well. Tactile disturbances. But here you often will find auditory disturbances, visual disturbances, headache, and clouded sensorium. So it presents a little differently than opioid withdrawal does. And opioid withdrawal is miserable for people, but it won't kill them. Alcohol withdrawal is a little less miserable for people, but it can kill them. So important for you to kind of differentiate that and to recognize it's really important to manage alcohol withdrawal consistently. Every hospital healthcare setting I've ever worked in has a protocol or a set of protocols to use, and we'll walk through what some of those might look like. So the one issue you have to look at, and I'll leave this for both the GI clinicians and the substance abuse uh, clinicians in ClinMed, is the Wernicke-Korsakoff syndrome. And you may or may not have discussed this already. You can read through this, but this is basically patients who are deficient in thiamine, and then you try to expend energy without thiamine, and they go through this uh, central nervous system transition process that is troublesome. And it's really prevented or managed by high dose thiamine on admission. Typically, if you've got somebody who's at high risk for this, we can give them as high as thiamine 500 milligrams intravenously 3 times a day for 3 days. If the patient is less high risk, we often will just get by with 100 or 200 milligrams IV times 1, and then maybe oral thiamine a couple times a day or even just once a day. But it's pretty routine that we'll give folks thiamine. Because of other deficiencies, they'll probably be on a multivitamin, folate. They may or may not be on an IV fluid bag. The advantage of IV fluids, if the patient's dehydrated, it replaces the fluids. The disadvantage in the emergency room of IV fluids in a patient with alcohol withdrawal and alcoholism is that they have to get up and pee, and in the process of getting up and pee, they fall and injure themselves because they're not really stable in walking. So, there's some arguments for not giving the IV formulation of what's called a banana bag. You may have heard of banana bags. Banana bags are liters of saline. We don't give dextrose because they haven't had that thiamine yet, but we give them a liter of saline, typically with multivitamins IV that are yellow in color, hence the name banana bag, folic acid plus thiamine. So that's infused, sometimes additional electrolytes if need be. Okay, so you want to pay attention to that. This is another sort of thing, the things you're thinking about for ancillary and nutritional deficiencies in alcohol withdrawal are B vitamins, particularly thiamine, but typically what you're going to find is all patients will also get often a multivitamin with minerals. By default, in most settings I've worked in, that happens to be a prenatal multivitamin. That's fine with them. They can tolerate those perfectly fine, and that's the usual course of events. There's guidelines for phenobarb or other GABAergic agents. I have worked in settings in the last few years that have used a phenobarb protocol in lieu of a benzodiazepine protocol for alcohol withdrawal. You can do either one. Your setting you work in is going to probably guide you. I am a believer in the phenobarb approach, although in this set of guidelines, they acknowledge that it works, but if you're not strict about how you dose it, you can overshoot it. So in any event, this is the specifics of doing a phenobarb versus a benzodiazepine titrated to maybe titrated or not titrated to a CWA score is a pretty standard thing you're going to get exposed to in your clinical year and your hospital rotations. So the kind of regimens that are used are benzos that are often triggered to CWA scores, phenobarb, which often is not triggered to a CWA score, but is a standard dose, but might have levels done, or maybe one of the other GABAergic agents that has some benefit in alcohol withdrawal. And then finally, for folks who have long-term alcohol use, the options we have are more limited for drug-wise. The tried and true response to alcohol use disorder that has worked now for more than half a century is AA, Alcoholics Anonymous. And the behavioral approach with the 12-step program, there are variations of this also for other substance use disorders as well, but it is probably the most effective thing for folks who are committed in remaining sober who have a problem with alcohol use. So I consider it a very strong behavioral support, networking, peer support process that has had a great track record for people who are motivated to remain sober. Drug therapy and alcohol use disorder is, without behavioral therapy, is almost doomed to failure. But with behavioral therapy like AA, may offer some additional support. I don't want to use the word crutch, but additional kind of minor support on top of the behavioral support. But again, you're kind of hearing that behavioral support is the mainstay of all of these conditions. So there's criteria for alcohol use disorder in the DSM-3. There are a number of meds that have been tried and have some data for assisting sobriety, but they are not, again, they are secondary, they're ancillary, they're additive, but not standalone therapies. They're on naltrexone. There's acamprosate, which is really kind of fallen out of favor, and its availability is even somewhat limited. Gabapentin, which again is somewhat limited. Topiramate use again is somewhat limited. And disulfiram, the old drug called Antabuse, which we really want to pick and choose who gets that. That would be a drug that someone takes daily, and if they were to start drinking, they have a severe flushing, nausea, and vomiting that makes them feel miserable. So it's a kind of a negative reinforcement process. And for the most part, most people who work in psychology or psychiatry would rather work with a positive reinforcement approach. Okay, that's it for substance abuse.